Colleagues, good afternoon. I suggest that we start. So, sorry that we are a bit late, but I'm sure that it's not a big problem. My name is Sergey Marian. Please take your seats. Our subject is quite specific and very interesting. It's going to be about big data in healthcare. Many people say that this is what everybody talks about, and it's not only about real results, the automatic system of diagnostics, advisors, decision-making system. So there has been a lot of things done and a lot of interesting tools that can help us solve very different problems. But I guess the main goal is not to speak about these instruments, these tools, but about the introduction of these tools in practice. So that's why I would like to make this session as applicable as possible. So I would like to ask you to talk about the application of different instruments, how you apply all those instruments in practice. Of course, there are many different risks of use. The people that make different solutions, and they cannot work in isolation from practitioners, and they cannot exist separately and in isolation from regulators and regulating authorities. So it means that AI specialists, regulators and doctors have to work together to produce a product. And this is one of the main problems. So it's a non-conventional process. That's why we have to work together to test, to hypothesize, to pilot run. And I hope that if we work together, we'll be able to come up with disruptive technologies. There's only yesterday and tomorrow when we speak about disruptive technologies. When we speak about the future and what we're going to use, so then we can look back and think about things that we used to have in the past. So let's talk about today, because it depends on today, what kind of technologies we will have tomorrow. And I'm really grateful to all the speakers, because these speakers can reflect the application aspects. We are having the deputy of Moscow Government Department, Vladimir Makarov. We are having a representative of Insurance Subdivision, Vladimir Zelensky, who is the head of Insurance Foundation for compulsory insurance. Insurance sector depends on data. And, we have to use it to control risks, to manage the results, and of course, insurance is closely connected to funding. That's why it plays the key role. We're also having Piret here, the head of Connected Health Cluster in Estonia. So they work as a technopark or a technopolis, and they work on data development in healthcare. So he will speak about practical application. We're also having Graham Rich. He used to be director of a large hospital in the UK. He is the governor. It's great that we are having such an international community. We are also having Dmitry Fadin, a director for innovations in vitro company, and Alexander Gusev. He is a co-founder of MIS company, and he works at the Center for Diagnostics and Telemedical Technologies in Moscow. So I hope that we'll be able to discuss how data is used in practice. So the practical aspects is what I would like to focus on. And now I would like to give the floor to Vladimir Makarov. Vladimir, the floor is yours. Yes, I'm here with you. Hello, everybody. I have been working with the Moscow healthcare sector for 10 years. From digitalization, automation point of view, there are many words and they're sometimes confusing. Whenever we speak about Moscow, we have to understand that it's a huge city, it's a mega city. So whenever we turn the process into an automated process, we work with digital data, and we work like that everywhere, in transport sector, education, healthcare. So this is one of the key things. Now, the second thing is that whenever we speak about healthcare, at least this is my view of things. You know, if we don't try to see the level of introduction of technologies in a specific institution, but take a broader outlook, overview of this sector, we can identify three major levels. So, information technologies have been embedded in medical institutions when most of clinical processes are covered with different means of automation. So there is data that is being accumulated. That is the first level of maturity. Now, the second level of maturity, we could interpret this data on the sectoral levels in a similar way. So it's about interoperability of different operation systems, the commonality of formats, semantics, the language that we use when we describe different events. And the third level is when the industry understands what they can do with this accumulated data, because it is now single and valid. So how can they use it and how to live with it? Most of the countries is coming closer to the second level, when they have a good legacy. So the state becomes the main provider and interested party. They would like to extract as much useful data as possible. So thus it becomes the most active driving force for the aggregation of different data. And we are somewhere between the second and the third level. Moscow has a beneficial situation. You know, when 10 years ago we started introducing information technologies in healthcare, we had greenfield in primary healthcare sector. We had only 3 or 4 really good polyclinics that we could be proud of, and nothing else. So we had to make the sockets because the computers had to be connected. So this created a very good competitive advantage, because we could build up the centralized system with centralized repository and and it was based on one of the most advanced technologies in describing that medical data. So I'd love to share some ideas with you. I'll share my vision and the challenges that we face, and I hope that we'll be able to discuss many different things and understand how we can make a next step forward. How can we really make all these accumulated data useful on the clinical level? So I'm a practitioner. I live with this every day. I'm not a futurologist. I'm quite skeptical, in fact. Moscow is one of the cities which is extremely interested in promoting advanced technologies. Sometimes marketologists are creating hype, but this is not who we are, because I have to live with this. I have to make it work in a large city, in many different institutions with tens of thousands of people working there. So what do we see in data management? First of all, management tasks, computer vision, and it's quite understandable. The third thing is the area that we started developing rapidly last year. Our data is well structured, so we are trying to add the systems for clinical decision-making support. And science comes as the next layer. People that work in science understand what we could do with this huge amount of information in Moscow. So our managers understand that if the opinion is not confirmed by data, it can be ignored. It means that any management solution has to be confirmed by big data. So management experts say that their opinion is not always confirmed by data. So now we are going to close 135 polyclinics for capital renovation. It means that we will have to move people from one hospital to another. And we have to think about transportation, territorial accessibility, and it will take us 2 or 3 years to complete capital renovation. So we have to do a lot of work. It's very difficult to create a roadmap and to make pathways for different flows. We are working a lot with the Foundation for Compulsory Insurance. We work closely together to optimize the flows. For example, for oncological medical help, to make it continuous and to close gaps between different stages, because time means life. I'm sorry if I'm saying something wrong. I'm sorry if I don't use medical terms right, because I'm not a doctor. I hope Vladimir will tell us more details about technologies and how they were distributed. Basically, it was based on objective need, and there are many examples. So data works very well in management. We can see it clearly. Now, if we move one level down, from hype towards more understandable level, and speak about the techniques and methods of data management, of course, they require improvement. I'm a person that make people work together, so I have to combine many different things and meet market requirements and respond to the needs. Because taking our situation into account, the state is the interested party, is the major stakeholder in using data. So it's quite clear that we have to develop different methods and techniques of working with big data, combine different data.
And we should understand what promising data is. We should also take them into account. So not only online data that are clear and understandable. So it should be processed, and it requires some probability, of course. So how well we connect it, the historical data and prospecting data. So what should we expect? And what should we use? What should we rely on? So success criteria. Someone should be interested in it. So healthcare, what Anastasia told about at the plenary session, quite brightly showed us. So healthcare, public officials, government, in most cases, they are not interested in all of that. So it's a model. So everybody feels quite comfortable, more or less. I don't want to offend anyone, but that's how we live. If you think about an outpatient clinic, a doctor who works at such systems, or having 12, 15 minutes for a patient, and we are talking to him about this proactive medicine, all this, so do this and that, and try to communicate with your patients better. And he says, I don't have time for that. I'm already overwhelmed. It's too many things to do. So even if we give tools that facilitate life of doctors, the implementation of these tools require a lot of efforts from doctors. So they are doing really great, because what we are doing with them for the last 10 years, I really feel shame for our IT work, because doctors are doing really great, but that's truth. So to understand that, so they didn't have any PC, so average age, it's not of the doctors, it's not 20 years. Of course, patients changed. We now have young people, but doctors still the same. So we give them computers and tell them now work with that. So this is this entry point. So while the doctor is pressing all these buttons at the PC with one finger, what can we talk about here? But 10,000 doctors found the possibility to take this, to have training, to learn how to type blindly with all the fingers. So we taught 10,000 doctors to type with all 10 fingers. The second criterion of success is be ready for surprises. And that's super interesting. Everything about medical statistics, so it's all about deception. So it's not someone's mistake, but all these numbers aggregated, and when you start explaining this or that phenomenon by using this initial data accumulated by online data, so when all this data accumulated through some business process, there are more than enough surprises. So the readiness to change the traditional, the political will to change the conventional way, the conventional mode. So everything that we are doing, big data, digital, will be totally useless if it's not a driver of this traditional way of life. So when I'm told that our doctors in medical institutions, in inpatient clinics, 60% fill out all these medical records, I say, let's make it all electronically. And I say, no, that's not the right answer, let's just stop doing it. So today was a great example when we stopped doing all the certificates. So we removed so many visits related to this certificate that you were not in contact with people with infections. So you don't have to go to a clinic now to get some stupid certificate. But before we needed that, because so the process required, so the process was needed, but the implementation was not correct before. So what to expect? So no one's interested, so we have the scale of responsibility, and they are shifting. So it's like everyone's doing it, so I can do it as well. So when we have transparency, then responsibility started to to focus in one place. So devaluation of expert institution, because mostly expert opinions, especially in management, are not supported by big data. And of course just human laziness. So why should we change anything at all levels? public officials, healthcare administration. No one wants to do anything, wants to change anything. So the change of philosophy, of mindset is really a very important step, and it's inevitable, unfortunately. So to change this traditional mindset, it's an inevitable fact that will happen. So computer vision, so it's quite clear, there are models with this or that probability. So we are trying it. We are not completely sure how to build in mass healthcare. When some breakthrough clinic explains how wonderfully this and that works there, how to implement it into the work process of tens of clinics and millions of workers, it's not clear. So these processes that we have to yet to create. So we launched an experiment. I will skip this. About unified X-ray information service. So we have this bank, this data bank, and later we'll have all the data. So checks, X-ray, CT, MRI, and so it gives a lot of opportunities. So we launched an experiment. And so Ministry of Healthcare is quite skeptical about all this artificial intelligence things. Fortunately, our leaders are trying to find a way. So now we are launching this experiment. So we have grant model. So we'll try to connect different models. Technically, we are ready to work with 5 companies. So if you fit to what we needed, you can also come to us and we'll try to work together. So system of support of clinical decision making. So they talked about it at the plenary session. So in medicine, so to make this algorithm in medicine should be based on this mass experience that we have. First of all, there is this factor that Dmitry Peskov mentioned, that when people start become transparent, and digital it's always transparent, they don't start lying, they start being more cautious. So understanding that there is some adverse effect when people may start asking questions why this or that. At the same time, we should understand, so let's have no illusions. So the medical area is developing very fast based on all this data received 25 years ago in the institution. So it's not exactly this ongoing education system. So we can't treat people using this 25-year-old knowledge. When we see this variety of options of treatment, so there are around 27,000 items in all these medical pharmaceutical guides. Our basic language, it's like 5,000–6,000 words. So you see, a doctor has a scope what he can use in his practice, and it's not always modern, not always updated. And using the retrospect, we can't make hints. We should use breakthrough technologies and some new innovative approaches and technologies. If we look how we treated patients before, we can create hints. It's not possible. A good gap is also a thing to discuss. So there is this gap between retrospective data to make hints for doctors, or maybe we use best practices that are shaped by our academicians, institutes, and so on, to create some position. So it's a very good dilemma. I don't know the answer. So we're trying both ways. So we digitalized really lots of things. So our data is really well structured. You can read about the methodology in the open air. I'm so tired to explain how electronic medical records are organized, because we clearly understand that it's not about documents, it's about data. So document is just a device, and it's not interesting. So behind any figure, there is some connection how this figure came. But in our engine there are no real documents. One of our colleagues, Andrei, so that's one of our guru, methodologist. So he wrote a whole book, how our electronic medical record is organized. So we're ready to distribute some free copies of this book, and he can tell you where you can download it and read, but not free of charge, unfortunately. But we'll try to bring this book to life, because it's kind of our Bible of so how we manage to understand all this from inside. So we used OpenHR and worked together with Scandinavian countries, with some Eastern Europe countries, where we thought they had some proper understanding of how this data should be organized, so that these data will not block by this informational system, that they'll have open access, so that any interested person will have access to it. So more in detail what we have, you can check at the website Digital Patient, but we really have a lot of data, several petabytes. So what to do with it? It's mostly a question to you. I'm a consumer, at least I represent consumers. So dear startups, IT companies, so startups can't live without some cooperation between doctors, clinicians, professionals, data professionals, and IT specialists. So it's just some sort of work, encourage you so we'd like to cooperate with you. So yes, we reached this stage, we have lots of data, we don't know what to do with this now. So I'm sorry if I took too much time. I hope it wasn't useless. Thank you very much. I want to ask one short question. So you said about government measures, because you represent the government. You said about the participation of startup and some other companies. What about doctors? So employees, so leadership team of hospitals, of clinics, what is their role in all this? And how can they contribute to implement all these technologies in their institutions? How do you see that? So as I noticed, so I think we tortured them quite enough, because it's very, it's not still working that stable as we would like that to. So there are so many pilots here and there. So first point, so it's sort of, we kind of raped them in a way. So like a pilot region, like a start-up region, who's pretending to be a leader in Russia and even in the world maybe. So we have to make this sacrifice, and I feel quite shameful quite often about our work. So their engagement in process, it's very different. There is no system. There will be no system unless a lot of people from this industry, so doctors, who helped us almost every day. So they really helped us every day, almost lived with us. So I remember when I spent a lot of time at one outpatient clinic, so I had keys from this clinic, from many offices in this clinic. It was very, very complicated. So the methodology, it wasn't possible to create this methodology without medical workers, doctors. So there is some amount of some crazy people who helped us, but in most cases they expect from us some breakthrough in terms of facilitation of their work. So like to cancel all the paper work, so to remove this burden from them, that they can really feel that we finally get over this step. I'm not sure if I answered or not, but I really, for these 10 years of my work, I feel only gratitude to our medical community, to our doctors, to chief doctors, to heads of departments. Like, let's do this and that very fast. So thank you very much, and I'm very, very sorry, but that was inevitable. My question was about future, not the past, mostly. What should they do now? We'll come to it later. Let's ask the doctors. I'd like to use the floor to Vladimir Zelensky, director of Moscow Foundation of Mandatory Medical Health Insurance. So what do you think about using data for this reason? Thank you, Sergey. So you said at the beginning about the combination of circumstances yesterday, today and tomorrow. As insurance, it's a very conservative topic, and this topic is directly related with taxpayers' money, as well as the assurance of coverage and all this insurance reimbursements. So today we have to make decisions that somehow will be taken by the system tomorrow based on data that we collected yesterday. So I'd like to continue what Vladimir Makarov said. So I've been doing it for 14 years for this mandatory health insurance, and I know that data are the most structured as for in relation to the health and medical care have been gathered for many, many years, and they always been most structured. Because from the very beginning of creating this mandatory health insurance system, all the clinics were supposed to provide companies with some kind of invoices containing a lot of data. So diagnosis, types of procedures, some unified IDs of patients, prices of different ways of treatments and technologies and different effects. So for us several years ago we had the real need to make all this data useful not only for ourselves or for insurance companies who process all these invoices and accounts. So quite often this system of mandatory health insurance, people think about it as sort of a treasury department. So like they're making all these checks and pay for their medical bills. So partly yes, that's what it is. But on the other hand, when we're serious about paying for all this medical care, the fairness of the price, the cost of the medical care, we start discussions with all this medical community. If our investments are fair and efficient in this or that technology, maybe we should pay more now for this or that procedure, and maybe we'll remove some expenses from us in the future for rehabilitation, for follow-up. Maybe will it free a clinic from some burden, from some payments, if we reduce how much time patients spend in clinic.
So there are quite many questions that the data would be useful for. Our Moscow Foundation collects information about 1.5 billion services, 5 million of ambulance cases. specific information about people that need insurance, that use insurance, their ID numbers. So we should use this data. We open this data for all insured people to get feedback from the insured, what they think about what we have paid for. It was very important for us that taxpayers had to see how much the state pays for different procedures, for different kinds of medical help that was provided, so that we could understand whether they were satisfied or not satisfied with the medical help that they received. We gather data for a long term, so this data can be used for management solutions, for different discussions with clinics. Yesterday at the plenary session, Mr. Larson was talking about value-based healthcare. So it's very important to understand the effectiveness for value-based care. And this understanding would be impossible without money, because it brings good effects for patients, for citizens and taxpayers, and it brings good effect for the state, which is the guarantor of medical help, according to the Constitution of the Russian Federation. So whenever we talk about economic effect, when we started processing data that we have, I can give you several examples. They are quite practical, and they were possible because we managed to accumulate a large body of data. It's true that the data is not very deep. It's not that they provide complete medical records, but we get information about millions of services given for millions of people. So this body of data can help us develop predictive analytics and understand what will happen later. Then there's another dimension to use this medical data, and it implies the response of the ministries, for example, when the tariffs are reduced or increased. It's not easy to describe this response using dry language by demonstrating a trend or a graph or some dry figures. So when we speak about changes, we have to understand, for example, how the system responded to different changes that took place, let's say, 5 years ago, and the dynamics of the scope of procedures. It could be related to many things, not necessarily the health or the procedures. It could be due to the changes in payment for the procedures. So this factor has to be taken into account. We are using different rules and, for example, and requests supplied by people. But there are also many other components that have to be taken into account. Anyway, I promised to give you several examples. So this is the first one. Several years ago, we moved on to machine use for identifying some suspicious services or suspicious cases for insurance company for expert review. You know, it's not a very pleasant procedure related to expert review, and control procedures. So we don't want to torture the organization. That's why we work together with insurance company trying to target this review so that the experts knew why they're going to clinics, what they should check. So we developed a register of chronic patients because we know their diagnosis, and usually the time scope is quite long, for about 10 years. And we also understand what services could be suspicious. Mr. Larson also mentioned package payment for medical help during delivery and during pregnancy period. And it was like bundle of payments model when we develop a set of rules, set up the price for this package, so to say, and thus we share economic risks. So if the clinic spends less, then we'll have to pay more, or if the clinic pays more, then we'll pay just a fixed price. So it's about sharing risks, and this has become possible for us when we switched to this payment model. We managed to group different services. It was very difficult for us to formulate the episodes and identify the connection between different clinical episodes. For example, a stroke and then pneumonia as a side effect, whether this pneumonia is part of a stroke fee or not. So it was very important for us to identify comorbidities, chronic states for patients. And once we formulated clinical episodes based on certain signs, and I want to emphasize, we don't have a very deep digitalization for each patient, but we have a lot of data for many patients. And then we started using the logic of economic evaluation, just to understand why patient costs more than the other one, whereas the model of payment was the same for both of those patients. So we are looking forward to gather more information for electronic records, because this would help us formulate the model for the patients more precisely, and then we'll be able to understand why patient was more expensive. So it means that we will have to incur some additional risks, or maybe the patient was more expensive because of insufficient work of a clinic, and then it means that it's the risk of the clinic and not of the insurance company. So this is what we're going to do. Thank you. Vladimir said that interessant was very important, so I guess the insurance company could become such interessant, or a stakeholder, and might become a driver that will drive efficiency and new business processes. I just want to make a brief comment. It's very often that the payer in healthcare sounds quite dry and can come up with very strict rules and block certain good initiatives, saying that we cannot afford these things. But we are trying to bring together many different parties, insured patients, clinics, as our counter agents that pay for medical help. So we could be a motivating link. It It doesn't mean that we carry out some punitive functions or only expert review functions. We are doing something that could be useful for all stakeholders. Thank you. Now maybe we should take a look at the international experience, and I would like to give the floor to the head of Connected House, Estonia.
Yes, can I have my presentation? Yes, I do have my presentation here. So, my name is Piret, and I will take you to a journey to the coolest digital society I believe that exists on the earth, and this is my home, Estonia. And I will explain you how we live our lives in Estonia, and I need to explain you also a few words about our background, because we do not live online life only in healthcare, but we have the same similar systems for all services provided by the government. So yes, it's not. Help, where, here. Do something. Сейчас будет. Ой, извините.
Информационные технологии в действии.
So yeah, welcome to Estonia. This was my message at first. Well, I have approached from different sides, actually. I'm a nurse by education, so I do understand what it means to deliver healthcare. I'm a person who is using the systems, and I have worked for the Ministry of Social Affairs in Estonia, so I do understand the policy level. And currently I'm working for the Science Park Technopole as a leader and manager of Connected Health Cluster, so I do understand how to implement and how to develop the services. So I kind of have the whole circle covered. And now you have to watch the movie because it's not changing. So the whole country is smaller probably than one region in Moscow. But it does not tell you anything about our systems, because the systems we're developing in Estonia, these are scalable. So it doesn't matter how many people are using the system. Is it 1.3 million or is it 13 million? Still the same system can be implemented. We do have a lot of people working for ICT sector, and this is historically so, but we do need also IT people from other countries, like we are using people from India, from Belarus, from Ukraine, because you see, 1.3 million people, not enough developers still. Our life expectancy is a bit below average if we compare it with Europe, but it's still, we can tell you that it's still the heritage from the Soviet times, but we are gaining up quite fast. And a few words about our healthcare systems. Our healthcare system is based on solidarity. It's funded by the government, so approximately 95% of our inhabitants do have public insurance, and public healthcare is available for every single person. There are a few essential points. So internet is a social right in Estonia. We Estonians, we do not show any emotions actually, but cut us off from the internet and you can see emotions. So this is something that we do require in Estonia, internet access. One really important aspect is that every Estonian resident has an electronic ID. And this is a key element actually to use and access all the electronic services in Estonia. We do have all the with few exceptions, we have almost all the services online in Estonia, and we do trust these solutions. I remember, probably it was in the other session in the morning where there was a saying that people do not trust. It's the opposite in Estonia, because we grew with the solutions since the early 90s, and we do trust our systems, and more or less we do trust our government as well. So this is one example of what we can't do online. This is the getting married. And not because it's technically not possible. We could do that, but you need to see your future husband at least once in your lifetime. So that's why. We need to do this offline.
And probably if it were too easy to get divorced, people would get divorced more often, eh?
No, you have to face it offline as well. So, yeah. There is a combination of three very important pillars. We do have confidentiality in our system. It means that we have this secure access to the systems. Availability. We have nationwide data exchange system called X-Road that actually delivers all the services, and integrity. It is the blockchain technology in our systems. The blockchain technology we are using in our electronic health record has nothing to do with the blockchain of certain currencies. So it's completely different, but we do use it to have integrity in our systems. So this is the picture actually of the architecture called X-Road. It's kind of X-Road, you know, where the roads cross, and that's why it's called X-Road. And this connects all the public and private service providers via internet. It's kind of state cloud where the data exchange happens. And you can see it's really busy annually and daily. So a few words about the key to our systems. I told you, I mentioned already before, electronic ID. So every single person in Estonia has one, and we are using it on a daily basis, and it actually grants you access to all the systems. But if you do not want to have online services, it does not mean that we exclude you from the society. Offline services are still available, you just have to go to the offices then, and it's quite uncomfortable. Looking at the weather you have here and we have in Estonia, so people prefer to use online services. And why it's so different from other ID cards? It has two functions. The first function is when I'm entering the system, I can actually identify myself. So my name is Piret and I'm entering the system. And the second step is authorization. In the morning, I can access the system as a doctor, Piret Hirv, and I can see different data, or not different data, but different interface. And I have different functions in the system. And in the evening, I can enter the system using the same ID card as a patient. And I have completely different services and different interface in the system. So this is quite important. And e-residency, Mark, just Google it. So every single one of you can become of e-resident of Estonia and enjoy the systems we have in Estonia. We do have few really clear and honest principles in our systems. Once only, if the government knows like your address or some diseases, not government, but doctor knows some of your diseases, then that's it. You don't have to report it twice or third time. They can access the systems and they can look what is wrong with me or where do I live. So once only principle is implemented. Digital by default, but as I told you, we do not exclude anybody who is living offline life. So trust by design, cybersecurity and privacy are quite important questions already when we're designing services. It might look like Estonians were kind of tree huggers, that we have this open access to the data and everything, but that's not the case. We are very private people in real life. Like if you travel across Estonia, you hardly ever see anybody because we are somewhere hiding. And this is the same actually in IT systems. We do appreciate our privacy highly. And I told you about the internet already. So a few words about healthcare. We do have digital health data. We have opt-out system, meaning that by default, every single person in Estonia has electronic medical data. If I don't want to show my data to somebody, I can opt out, meaning that I can close my data from being used or to show the doctors. This is the case usually with HIV, for instance. I don't want my family doctor to see that I do have this infection. But then when I close the data, then the system gives me warning that now you're closing your data, but you should be aware that now doctors can't treat you properly because the whole picture or the whole data should be available for the doctors. Digital prescription, it was implemented 2010, so 10 years ago already, and every single person in every single pharmacy and family doctor's practice is using it. It's 100% in use. E-ambulance. I saw that you have also here presented this ambulance car, but our ambulance is actually equipped with a smart device. So every single doctor who is sitting in the car or paramedic, they do know already medical data of the patient before arriving to the place of scene. So they know all the allergies, chronic diseases, infections, heart failures, if they know the name or ID code of the patient. And personalized medicine, this is something that we are planning for the future. This picture actually shows you all the data sets, not all, but main ones that our medical institutions and services are using. So actually, for the science and policy making, we have this anonymized health data set. And the beautiful thing is that my medical data is not one medical card somewhere in the files. But actually, when I enter my ID code to the system, then the system starts asking questions from different data sets, like a population registry. Where do I live? How old I am? So my like general information comes from there. From a nationwide health information system, all my diseases will be connected to the picture. From the prescription center, all my medicines prescribed to me will connect it to the picture. So this ID card not only grants access to the system, but this also integrates all the services available. Yeah, and this is the picture of nationwide services we have at the moment. So you can see that we started in '95. It's not a revolution in Estonia, it has been an evolution. And you mentioned political will, and political will actually is the key element here. It all started with a political will back in the 90s. Future. We do have genome bank in Estonia. Currently they have 200,000 samples in the genome bank. And I wouldn't say that it will happen this year or next year, but in the nearest future, we are planning to combine genome data with medical records and to predict the risks of the patients. So family doctor, when I go to the family doctor's office, she will know my genomical background and also my medical history and prescribe me better medicine. This is the place where I work. And I need to I want to underline, if I can do that, thank you. This is actually how it looks to implement or develop services in healthcare. You need a lot of support. And I will just, and for that we have a special platform called Connected Health, where we bring together all the doctors, patients, IT companies, startups, universities where they do science, pharmaceutical industry. They do not need support, but they need also innovation. Public sector, Ministry of Health, Health Insurance Fund. So they are all part of this network, and what we do there, we do implement and we do develop all the services together. So from the day one, you need to involve all the stakeholders. I told you about political leadership. Lessons learned. We have made a lot of mistakes. I'm not going to list all those mistakes here. Just come to me and ask, or come to Estonia and learn what are the mistakes. But few key lessons, like keep it short and simple. Transparency is the key word here. You need to be transparent. Delivery matters, so does design, and you have to deliver value-adding services. Yes, people are lazy, but if they see value in these services, they start using it. And that's it. So thank you.
Thank you very much. Thank you, Piret. Я хотел передать слово.
I'd like to give the floor to Graham Rich, who will tell us on his experience as former head of quite big clinic in the UK, how to use AI data.
Okay, and it's a pleasure to be here. Thank you very much for the opportunity to speak. I'll keep it fairly brief, given the timing of the session. So big data is hugely in the news at the moment. You know, we've seen just in the last 3 weeks a report from Stanford that interviewed 900 doctors and doctors in training, and most of them expect about a third of their activities to be automated within 10 to 20 years. We've seen the paper in Nature that took large data sets of mammogram information, and a team in the UK and the US was able to use that data to train the machine to recognize breast cancer more successfully than humans, and reducing the workload of radiologists who are reviewing a previous radiologist's report by 88%. So it's in the news. It's been a topic of hype for a long time. So the question I ask myself as a manager, as a previous manager and as a consultant now, is can it solve one of the world's biggest problems, which is healthcare costs are going up every year. We're all growing older. We're living with more and more conditions. So can big data help us in this regard? So I want to pick out a few examples, but before I do that, I want to just talk about the necessary conditions for using big data sets, and we've heard some of this already from Estonia. You need reasonable data quality. Clinicians across the world worry about data quality, but you can use big data sets that are not perfect. Either you use machines or humans to clean up the data sets, and they can provide you a lot more insight and action than you can imagine. You need appropriate confidentiality. So about 6 years ago, we had a hiccup in the UK use of big data sets as the public were concerned about consent. So you need to be able to anonymize data for system planning and other purposes, and it to be only identifiable if you yourself are personally going to benefit from the decisions that come from that. And you need appropriate governance so that that confidentiality and trust is preserved. In the UK, we've got quite strict data protection laws and a National Information Commissioner that can investigate and prosecute people that misuse data. So there's some pieces that are useful. I should say that I don't think use of big data should be restricted to state-run organizations. You know, we have an enormous National Health Service in the UK. Nearly all healthcare is provided by the state and paid for by the state. But we're seeing a lot of innovation from small and big companies coming in. So you need some sort of partnership where different companies can use big data sets to be able to provide innovation quite rapidly, probably faster than a multi-tiered, traditionally bureaucratic, traditionally conservative organization can do. So in the UK, we've got a number of pieces of data. The hospital data sets are very similar to the claims data that we heard for the insurance system here: age, sex, diagnosis, where the person came from, where they go after hospital, outpatient attendances. And then you have full EPRs, electronic patient records, in a number of hospitals. In primary care, it's excellent. We've got good longitudinal data. We've got nearly 20 years of healthcare data in primary care. So what can you do with this? One project that I was involved with, the Boston Consulting Group in the UK, we had a hospital who had lots of readmissions, people that go out and then come back in quite quickly. Using some of that basic information, we were able to predict with reasonable degrees of accuracy which patients are most likely to be readmitted, which allowed the hospital to put in extra care for those sets of patients to reduce the number of readmissions. And this was in a consequence of a financial penalty for people being readmitted. So it's an example of quality-based payments, if you like, value-based payments. Larger data sets, particularly when you combine primary care and hospital care, are being used in the UK in lots of different areas to stratify the whole population. So who in the population are at low risk of hospital admission, which ones are medium and which ones are high. And you look at the criteria and you can design successfully interventions to reduce hospital admission. So this can have a direct impact on total healthcare cost. What this has done is to level off the increase in hospital admissions in those areas that have done it. The other piece is when you take the very rich data of the hospital, you can get into even more interesting use of predictive analytics. Royal Free Hospital in London has worked with Google DeepMind to identify and recognize people at risk of acute kidney injury in hospitals. And the Boston Consulting Group also did this in Paris. So now in the Paris, several of the Paris intensive care units, an app will run the data on all the patients in the units, and it will identify all of the patients that are at risk of acute kidney injury. It identifies 82% that are about to go into acute kidney injury, allowing clinicians to change what they do. Another example project that's been involved in is using big data sets to predict who will respond to chemotherapy in certain types of blood cancer. So rather than having a first line and a second line treatment, some people will go through first line treatment and not respond. So the patient finder tool allows you to identify those people where you're wasting your time and your resources and wasting the patient's time, and you should go straight to second line. So I just want to finish with a couple of thoughts on this. So can it solve the healthcare cost problem? I think it can play a part. The biggest challenge here is once you have an insight, once you have predictive analytics, then you have to work with lots of different stakeholders and clinicians and services to change what they do. And the hardest piece of this is human behavioral change in terms of making these changes happen. Once you combine that with big data sets, then you can have a massive impact on total healthcare costs. Thank you.
Thank you very much.
Yes, it's true of all the industries. We see that it can't be done without a person, and so a human can help and can also impede, so we should change humans' behavior. Now I'd like to give the floor to Dmitry Fadin, so Director of Innovation in vitro company. Please share your point of view. Now discussion, I think that we are quite look at this big data from kind of side view, like it's not close to us, like it doesn't concern us, but it concerns all of us because all the medicine is based on evidence, and it's based on this check of through big data. So all the lab tests that our company started with, so the first thing was to digitalize all the data. So we always work with digital technologies. It's not something new. For instance, I had my PhD on big data in 1995. So it's not some innovation that just caught up with us quite unexpectedly. It was very fast, brief presentation. It's okay. I can do without it. So we should pay some more attention to some aspects. First of all, what I find important is data itself. So are they big? It doesn't matter, but what matters is that this data would be properly selected, validated, and compared with clinical information. And there is such a principle in informational systems. If you put some garbage into this informational systems, so at the back you get the same garbage, but processed by this system. So in this way, it's very hard, and I support, it's very hard to work with retrospective data, because if you don't know why you collect them, so if you don't have this processing model, you can't collect them properly to further process them. That's why we only work with prospective data, though we have, fortunately we have such an opportunity. So during the year we gathered about 80 million lines of data and about 15 million patients. So we can first create anthology and then collect the data for this model. And second thing is how these data are processed and presented. How do you present the result of the system will really change its perception. So one of the cases that I'd like to show, you participate in big national program demanded by the Minister of Defense to assess by the readiness of the population to a big number of infections and the efficiency of vaccination as prevention. And one of the big part of this work is the analysis of this data across different regions, including Moscow, how efficiently vaccines are working. So can we say that immunity is based on this vaccine, on the vaccination, or that because person just got sick and got this immunity? For instance, if we have polyvalent vaccine, for instance, measles, rubella in same one situation, it's quite hard to say if the person got all of them. So probably it happens that people got all three, but statistical probability is 1 to 5 million. But the probability that this immunity got thanks to the vaccination is quite high. So quite likely that the vaccine worked for all three components. And it's quite likely that we can separate people vaccinated and people who were not vaccinated. And just an example. So distribution of this data across geolocations gives us significantly more information than just these lines with this data. That is why I think it's very important to think how we present this data. So maybe we don't know, but a lot of data that are used that are not really shown, like under the hood. So we think that some doctor replacement comes, we complain, and then we get out healthy. Now 80% of what's going on is really not seen. So many things related to the analysis of big data. For instance, we use the quality, the reproducibility and consistency of the data. And the last case that I'd like to tell you about the support of decision-making process, sometimes it works in a way that we are not supposed to solve a problem, how to replace a doctor to make him better, but sometimes it's more important to make him faster. So for instance, we participated in the development of a system that helped the admission doctor what to do with the patient here and now. And it's not only a system of data analysis, but also an interface is made. So instead of gathering all this medical history, this person has really make a very fast decision what to do with this patient, and later will collect properly all the data. So that's why interface and analytics system and all this together, they are organized in a way that to solve very fast the small issue. So the more global things we put, the less chance we have to solve them. If we create a very long plan for the future, understanding where we want to go, but we go by small steps, then we have much more chance to get this as a. So we should really have a look if we manage to achieve what we wanted. And to wrap it up, as we're always out of time. So everyone sort of like oil So I think it's like shale oil, that you have to a lot of effort to achieve it. And this AI, it's like electricity, but that's like walking through this dynamo machine, so by hand, so not really.
So it means that we have to take it all into account, otherwise we won't get any results. So it's very difficult for the state to be the only big stakeholder. It's much better when there are several stakeholders. So if you have any ideas as to what kind of benefits you can get, it would be great. Thank you, Andrei. I liked you saying that big victory consists of several small victories. And now I would like to give the floor to Alexander Gusiev, who is a member of Expert Council of Healthcare Ministry for Healthcare ICT. I'm sorry, but you can have a shorter time for your talk. Okay, I'll just would like to tell you about several cases, and we used AI to fight against chronic results, in particular cardiovascular diseases. So there is a lot of serious research that says we need to stop reinventing the wheel and develop different scales and methods of examination. It's more important to start working with prediction, with forecasting, to expand data in order to increase the precision of different measures. So there's a lot of research and many specific examples in this area. In particular, we were inspired by the project from the UK that used a lot of big data and proved that the algorithm based on big data can improve your forecasting ability and prognosis and forecast. So that's why we developed our system that combines classical scales and machine learning based on large body of big data in order to predict a certain cardiovascular event. At the moment, we work with two models that are quite accurate, so we are not quite happy with the results. We understand that they have to be improved. However, we launched several practical projects that use that algorithm. This algorithm works in a simple way. It's inside web service, and then it is integrated with electronic medical records, so the doctor can press the button. We basically called it Ask AI, so depersonified electronic records of the patient went to the service. Then this algorithm examined everything and trying to evaluate the risk. If there's any probability of a critical event, it could be a cardiovascular event or atherosclerosis or any other event. So if this patient had a high risk of this, then the doctor would receive the recommendations. And a pilot project that we delivered together with the Association of Yamal Healthcare Department and the Ministry of Health. So we managed to evaluate all the adult population to 100%. So we passed all this data through AI mechanisms, and we identified several things. For example, a scale that is used for checkups does not work does not always work. For example, the patients might have some cardiovascular events after they visited a prevention center. So we provided real figures based on real population in one region, Yamal, that showed that there's a very big potential to improve these indicators. We also completed research, so it showed that if the doctor uses conventional methods without any process reengineering, in 10% of cases, the preventive doctors put the patient that he belonged to category of the one of health state. However, this was a highly risk. These patients had belong to the high-risk group, and in many cases we identified a lot of cases, and it meant that there were very many patients that had to have a treatment and to get prescriptions in order to postpone certain traumatic effects related to their health. Thank you, Alexander. I would like to thank all the speakers. Unfortunately, we have run out of time. We won't be able to take any questions from the audience, so let me thank all the speakers for their interesting presentations. I would like to add one thing. So there are people that develop such systems, the state regulators that come to clinics trying to develop processes, but I think that it would help if everybody went deeper into this process, so that you all could see what kind of results artificial intelligence can bring, because we can see lack of trust and skepsis, because it's not about the doctor substitution. AI can be a good advisor, and I encourage you to take a closer look because it can really improve your process. Thank you very much. Thank you for participation.